there, curious minds. Welcome back to the Deep Dive, where we sift through mountains of information to bring you the sharpest insights and those aha moments you didn't know you were missing. Today, we're embarking on a pretty fascinating journey, actually. We're going deep into the hidden architecture of your jawbones. We're exploring something called benign nonodontogenic lesions of the jaws. Sounds complex, I know. You've given us some really comprehensive material here, a real deep dive into this very specific but vital area. So our mission today is to cut through that complexity, maybe demystify some of the jargon for you, and really pull out the most critical nuggets of knowledge so you walk away feeling incredibly well informed about conditions that, frankly, often fly under the radar.
That's exactly right. And the challenge with a lot of these lesions, well, they can often look quite similar, clinically and on x-rays, but they can have vastly different implications and crucially different treatments. So we're going to try and illuminate those key distinctions for you, look into their known causes where we know them, and really highlight the practical considerations that make understanding these jaw-specific conditions so important.
Okay, let's unpack this then. We're talking about a diverse group, right? Growths and conditions found in the jawbones, but crucially, they don't originate from the tissues that form teeth. So think of it maybe like a spectrum. We've got things like fibroosseous diseases where normal bone gets gradually replaced, to giant cell lesions with these, well, intriguing cellular makeups, and even some nonodontogenic cysts that are actually surprisingly common. Let's start with that big umbrella term you mentioned, fibroosseous disease. What exactly ties these conditions together, and why are they notoriously tricky to classify?
Yeah, you've hit the nail on the head there. The common thread, the thing that links all fibroosseous lesions, is that normal bone gets replaced. It's replaced by a fibrous tissue. You can sort of think of it like scar tissue, which then matures. And as it matures, it incorporates varying amounts of mineralized material. Sometimes it's bone, sometimes it's something more like tooth cementum. Under a microscope, telling the subtle differences apart can be incredibly difficult. It makes diagnosis a real puzzle sometimes. So for our discussion today, let's focus on three main groups: fibrous dysplasia, somatoosseous dysplasia, and ossifying fibroma.
Okay, starting with fibrous dysplasia. The name itself kind of suggests a developmental hiccup, doesn't it? What's the story here?
It is, yes. It's essentially considered a developmental hamartomatous condition. Now, for our listeners, a hamartoma isn't really a true tumor. It's more like a disorganized overgrowth of normal tissue. Just, well, not put together right, where it should be. In fibrous dysplasia, there's a theory, a proposed genetic link involving a mutation in the GNAS gene. This mutation leads to defective osteoblastic differentiation. So the cells meant to build nice, organized bone, they don't develop correctly. And you end up with this fibrous abnormal bone tissue instead.
Right, so a mix-up in the bone building process, and it can show up just in one bone or sometimes more widely.
Exactly. It can affect just one bone. We call that monostotic, or multiple bones, which is polyostotic. Sometimes it's even part of a bigger picture, like in McCune-Albright syndrome, which also involves skin pigmentation and endocrine issues. Then there's the craniofacial form, confined to the head and face. And the jaws, well, they're a very common spot for all these types. The maxilla, the upper jaw, maybe slightly more often than the mandible.
Okay, so what would a patient typically experience if they have this? What are the signs?
Often, the very first sign is just a painless swelling. Usually this appears in the first or second decade of life. Radiographically, on an x-ray, it has this classic ground glass opacity.
Ground glass.
Yeah, imagine looking through a frosted window pane. It's hazy because the bone structure is so fine and abnormal, and it usually lacks clear borders. As it expands, it can actually push teeth out of position, or even narrow critical passages like the optic canal behind the eye. Though, interestingly, surgery just to relieve vision issues hasn't shown much success there.
And you mentioned it has periods of activity, so it's not just static, it changes over time.
That's a really crucial point. Yes, active lesions can definitely cause symptoms. Things like throbbing pain, discomfort, increased swelling. They can even appear hot on a bone scan, which sometimes makes us think it could be an infection.
Ah, okay.
But the good news, generally, is that it typically burns itself out, becomes quiescent by the late teens or early 20s. However, and this is a critical nugget for you to know, although it's rare, there are reports of sarcomas change.
Meaning it becomes malignant.
It's exactly, a malignant transformation. Sometimes it's been linked to prior radiation therapy, but it can also happen spontaneously, which really highlights why we need careful long-term monitoring for these patients.
Right, so if it often calms down on its own, what does that usually mean for treatment?
Well, treatment is primarily symptomatic. If it's not causing any problems, a biopsy just to confirm the diagnosis might be all that's needed. There are medications, bisphosphonates, that can sometimes help slow down the bone turnover. If surgical recontouring is needed, maybe for cosmetic reasons or functional issues, it's best done during that quiet, quiescent phase. Because active lesions are highly vascular, lots of blood vessels, and they can bleed quite a lot during surgery.
Ah.
And recurrence rates, well, they can be significant, especially if it's treated too early in a younger patient, sometimes as high as 25% to even 50%.
Wow. Okay, let's move to the next one you mentioned, cemento osseous dysplasia, or FEOD. You said this is probably the most common fiber osseous disease in the jaws,
There it is, yeah.
but maybe less of a clinical headache than fibrous dysplasia.
That's generally true, yes. And what makes CODIs particularly interesting, and often less of a dilemma, is that they are frequently asymptomatic. Many require no treatment at all. They involve this sort of disordered production of bone and cementum-like tissue, but specifically in the tooth-bearing areas of the jaws. And we often see a striking predominance in middle-aged African-American females. That's quite a specific demographic finding worth noting.
Interesting. And there are different types, different forms of CADA, right?
Absolutely. There's the periapical form, which you
Mhm.
find around the roots of otherwise healthy, vital teeth, usually in the front part of the lower jaw. Then there's sulcal cod. That often pops up in areas where teeth have been extracted, or just in edentulous spaces without teeth. Florid setae is more extensive. It involves multiple quadrants of the jaws, often with larger, denser masses. And these have a higher risk of infection, which can definitely be problematic. And finally, there's something called familial gigantiform cementoma. This is a rapidly growing variant. It's autosomal dominant, so it runs in families. It doesn't seem to have that racial predilection, and it often does require surgical recontouring, mainly for cosmetic reasons, because it can get quite large.
So different ways the same underlying process might show up. Okay, now let's turn to the true neoplasms in this group, like ossifying fibroma. How does its nature as a true tumor change things compared to, say, the developmental fibrous dysplasia?
This is where it gets really impactful, clinically speaking. Unlike fibrous dysplasia, an ossifying fibroma is considered a true neoplasm. It's a genuine growth, a proper tumor. And that classification changes everything about how we approach it.
Okay.
Typically, it appears as a solitary lesion, usually well demarcated, kind of distinct from the surrounding bone. It often has a mix of radiolucency and radiopacity on X-ray. We see it more commonly in the mandible, the lower jaw, and it tends to appear a bit later in life, often third and early fourth decades. There's a female predominance, but no specific racial link like we see with SETI.
So because it's a true tumor, the treatment approach must be fundamentally different then.
Precisely. The standard treatment is surgical excision. And what's often quite remarkable during surgery is that it tends to shell out easily.
Shell out.
Yeah, it separates cleanly from the surrounding normal bone, almost like it's in its own capsule. Makes removal usually straightforward. However, the recurrence rates can vary wildly. Some studies report as low as 1%, others up to 63%.
Wow, that's a huge range.
It is. And sometimes, especially if it's in a tricky craniofacial location, more aggressive surgical approaches might be necessary.
And you mentioned a variant that sounds a bit more concerning, the juvenile aggressive ossifying fibroma.
Yes, that's a specific subtype that occurs in younger patients, children, and adolescents. Now, despite the name aggressive, it doesn't always require truly aggressive radical surgery. Conservative excision is usually recommended first. But you're right to be cautious. The recurrence rates are higher, somewhere between 20% and 50%, particularly in these younger patients. It also has specific features under the microscope, defined by the World Health Organization, like a very cell-rich fibrous tissue with these characteristic cellular osteoid bands.
Okay, let's shift gears a bit. Let's talk about lesions containing giant cells. The source material points out that under the microscope, many of these look really similar. So how on earth do you tell them apart?
That's an excellent question, and honestly, it's one of the biggest challenges in maxillofacial pathology. Histologically, looking at the tissue slides, many giant cell lesions can appear almost identical. So differentiating them isn't just about what the cells look like. It relies heavily on the clinical picture, the patient's history, age, location of the lesion. And often we need more advanced techniques like immunohistochemistry, which uses antibodies to identify specific proteins in the cells or even genetic markers in some cases. We really have to be detectives.
Okay, so the central giant cell granuloma, CGCG, that one's almost exclusive to the jaws, right? What's its typical story?
Yeah, its exact origin, the histogenesis, is still a bit speculative. But we primarily find it in the anterior parts of the jaws, front of the mouth, often showing up in the second and third decades of life. Now, historically, it was sometimes thought to be a reparative lesion, something the body might even heal on its own. But the current thinking, the consensus now, is that if you leave it untreated, it's generally progressive. It will continue to grow. Radiographically, it can look quite variable. Sometimes it's a well-defined radiolucency, sometimes ill-defined, sometimes even multilocular, like soap bubbles, and it can definitely displace teeth.
And these giant cells that give it its name, what are they actually doing in there?
That's been figured out largely through immunohistochemistry. These large, multinucleated giant cells, they're actually osteoclasts.
Osteoclasts. Those are the bone-resorbing cells, right?
Exactly. They're the cells responsible for breaking down bone tissue.
Mhm.
The smaller spindle cells mixed in with them are thought to be the actual neoplastic or originating cells of the lesion itself.
Okay. And when it comes to treatment, is surgery always the first step for CGCG, or are there other options on the table?
Well, surgical curettage, basically scraping out the lesion, is usually curative. But there is a recurrence rate, maybe around 15–20%. For lesions that are particularly aggressive or very large, sometimes more extensive surgery might be considered.
Mm.
But here's where things get really fascinating, I think. There's been a lot of exploration into non-surgical options.
Really? Like what?
Things like intralesional steroid injections, usually done weekly right into the lesion. Also, calcitonin, which is a hormone. It can be given as a subcutaneous injection or even a nasal spray. Calcitonin seems to work because these giant cells, the osteoclasts, have calcitonin receptors on them.
Ah, interesting.
And even interferon alpha has been used. That's thought to work partly through an anti-angiogenic effect, meaning it reduces the blood supply to the lesion. So these therapies suggest that sometimes we can actually stimulate a natural healing process without needing surgery. And this is absolutely critical, a key takeaway for you for any giant cell lesion in the jaw that is recurrent, looks particularly aggressive, or if a patient has multiple lesions. It is absolutely essential to rule out hyperparathyroidism.
Hyperparathyroidism, what's the connection?
The brown tumors that can occur in bone as a result of hyperparathyroidism are clinically and histologically identical to CGCG. They look exactly the same. But the difference is brown tumors will completely resolve once you treat the underlying parathyroid gland problem. Missing that diagnosis could lead to completely unnecessary jaw surgery.
Wow, okay, that is critical. Now, cherubism, that name sounds quite distinct. Does it live up to its unique moniker?
It absolutely does. It's a familial condition, meaning it runs in families, and it's genetically dominant. It often affects the facial bones quite symmetrically, especially the maxilla, upper jaw, and the orbital floor below the eyes. This can give children that characteristic cherubic or plump-cheeked appearance, hence the name.
Ah, okay.
The specific genetic defect has been pinpointed to chromosome 4p16.3. Radiographically, on X-rays, it typically looks honeycombed or multilocular and can be quite extensive, often displacing developing teeth. Histologically, again, it looks very similar to CGCG, but one subtle microscopic feature that can sometimes help distinguish it is something called perivascular cuffing.
Perivascular cuffing.
Yeah, imagine tiny blood vessels within the lesion surrounded by a little halo or cuff of cells. It's a subtle clue, but can be helpful.
And treatment for cherubism, is it similar to CGCG given the histology?
Well, because of that histological similarity, calcitonin has been tried, but it's had pretty variable success, which suggests that despite looking similar under the microscope, they probably are fundamentally different lesions. So treatment is usually conservative and expectant. You monitor the growth, maybe help guide tooth eruption if needed. Cosmetic recontouring surgery is often deferred until the lesions become less active, which typically happens in the late teens and 20s. They often regress somewhat naturally during that time.
Okay. Let's move on to another category. Nonodontogenic cysts of the jaws. I'm guessing many of these are silent discoveries found by chance on an X-ray, maybe?
Many are, yes, that's very common. These are cysts that, by definition, aren't derived from tooth-forming tissues, the odontogenic apparatus. Interestingly, some entities that used to be classified as fissural cysts, the idea was they formed along lines where embryonic parts of the face fused together, like the globulomaxillary cyst or median mandibular cyst. Well, that whole theory has largely been debunked now.
Oh, really?
Yeah, most cases that were previously diagnosed like that have now been reclassified as other types of cysts, like odontogenic cysts, or even certain tumors. However, they still exist as important radiographic and clinical findings that need proper investigation to figure out what they truly are.
Gotcha. So what's a common nonodontogenic cyst that we do still recognize and diagnose today?
The nasopalatine duct cyst is a really common one. It's also called an incisive canal cyst. You find it right in the midline of the palate, just behind the upper front teeth. Often it presents as a soft swelling there, or it's just found as an asymptomatic radiolucency on an X-ray.
And where does it come from?
It's believed to arise from epithelial remnants, leftover cells from the embryonic nasopalatine ducts that run through that area during development. A useful rule of thumb on radiographs is if that nasopalatine canal looks wider than about 7 millimeters, you should suspect a cyst might be present. Treatment is usually straightforward. Surgical curettage, just scraping it out. One potential side effect is a small area of numbness on the front part of the palate.
Okay. Now here's one that sounds almost like a contradiction of the traumatic bone cyst. A cyst possibly caused by trauma. How does that work?
This is one of those truly surprising and interesting nuggets in jaw pathology. It's also sometimes called an idiopathic bone cyst, meaning we don't fully know the cause, or a simple bone cyst. It's almost always asymptomatic, found completely by chance on routine X-rays, usually in the posterior part of the mandible, the lower jaw. Radiographically, it typically appears as a fairly well-defined radiolucency, but with these characteristic scalloped margins that curve up between the roots of the teeth. Someone once described it poetically as looking like a pencil sketch for a final pen and ink drawing, suggesting its somewhat subtle or indistinct borders compared to other cysts.
Huh. And the cause? Still debated.
Still debated, yes.
Yeah.
But a leading theory connects it to some kind of trauma, maybe a knock to the jaw that causes bleeding within the bone marrow and intramedullary hemorrhage. The idea is that this blood clot fails to organize and heal properly, and instead it breaks down and leaves behind an empty space, a cavity within the bone.
So what do they actually find inside when they go in surgically?
Well, that's the fascinating part. Surgical exploration typically reveals just an empty space, maybe sometimes a small amount of straw-colored fluid, but usually with little to no discernible lining tissue.
Just empty.
Pretty much. And here's the really intriguing bit. Simply performing the biopsy itself, which involves entering the cavity and causing some fresh bleeding into that space, is often curative.
Just making it bleed cures it.
In many cases, yes. The new blood clot organizes and the lesion resolves. These lesions can apparently even regress spontaneously sometimes without any intervention at all. Makes them quite unique.
That is wild. Okay, and another chance finding that often needs no treatment. You mentioned Staphney's bone defect.
Yes, Staphney's bone defect, or Staphney's cyst, although it's not a true cyst. This one is always asymptomatic. It appears on an X-ray as a very distinct, well-defined, corticated radiolucency located right on the lower border of the mandible, specifically below the inferior alveolar nerve canal. Its appearance and location are usually so characteristic, so diagnostic, that a biopsy often isn't even necessary.
So what is it, if not a cyst?
It's actually not a cavity within the bone, but rather an indentation or depression on the inner surface, the lingual side of the mandible. And that indentation is typically filled with a little lobule or offshoot of the submandibular salivary gland, which sits right below it.
Ah, so the bone just formed around a bit of the gland.
Essentially, yes. And because it's just an anatomical variation, no treatment is needed at all, which is certainly a welcome finding compared to many other things we've discussed.
Definitely. Okay, moving away from cysts now. Let's talk about Paget's disease of bone. This sounds like something from, well, a very old medical textbook, Osteitis deformans.
It is indeed. It was first described by Sir James Paget way back in 1876. It's a slowly progressive chronic bone condition. The exact etiology, the cause, is still unknown. It predominantly affects older adults, typically males over 50. And what happens is this accelerated chaotic cycle of bone remodeling. You get excessive bone resorption, breakdown, immediately followed by excessive, disorganized new bone deposition. This leads to bone that is enlarged, deformed, and structurally weaker than normal. It can affect multiple bones throughout the body.
And in the facial region.
In the head and neck, the maxilla, the upper jaw, is affected more often than the mandible.
So physical changes would be a pretty big indicator then.
Absolutely. Classically, patients might report that their hats suddenly feel too tight, or their dentures no longer fit because the jawbone has expanded. Radiographically, especially in the skull and maxilla, you see this characteristic cotton wool appearance. Yeah, it looks patchy, with areas of density mixed with radiolucency, reflecting that disorganized bone structure. You also often see hypersmentosis, excessive cementum buildup on tooth roots, and loss of the lamina dura, the thin white line around tooth roots on an X-ray. These changes can make tooth extractions extremely difficult in patients with Paget's. But here's the really crucial why it matters nugget for you beyond just the bone changes. Paget's disease can lead to some serious systemic complications.
Like what?
Well, because there's so much metabolic activity in the affected bone, it requires a vastly increased blood supply. This can actually lead to high-output heart failure in some cases.
Wow, from a bone disease.
Yes. And perhaps even more significantly, there's a recognized risk estimated between 5% and 15% of malignant transformation, usually osteosarcoma, a type of bone cancer arising within the Pagetic bone.
Okay, that's serious.
It is. So beyond the localized bone issues, the potential for these systemic complications makes early detection and management absolutely vital. Treatment usually involves systemic medications like calcitonin or bisphosphonates, which help inhibit that excessive bone resorption. And sometimes localized surgical recontouring is needed for functional or cosmetic reasons.
Wow, what a journey that was through the often unseen world inside our own jaws. We've really covered a lot. Everything from the genetic mysteries of things like fibrous dysplasia and cherubism to the, frankly, bizarre spontaneous healing of traumatic bone cysts, and then the potentially serious, far-reaching implications of something like Paget's disease. It truly highlights how much can be happening beneath the surface, sometimes silently, sometimes with really profound consequences.
It certainly does. And I think the sheer diversity of these benign nonodontogenic lesions, the way their clinical signs and radiographic appearances can often overlap, and the absolute need for a precise diagnosis, it all really underscores the complexity of maxillofacial pathology. Understanding these nuances isn't just an academic exercise. It's absolutely crucial for accurate diagnosis and for guiding effective patient management, making sure we recommend the right treatment, or sometimes, importantly, recommending no treatment at all.
Absolutely. And for you, our listener, we really hope this deep dive has given you a fresh perspective, a sense of the intricate workings of the human body, and also how medical understanding is constantly evolving. What really stands out to you from all this? Maybe it's that counterintuitive idea that just doing a biopsy can actually cure a cyst. Or perhaps it's that critical reminder to think systemically, to rule out something like hyperparathyroidism when a jaw lesion looks identical to a local condition like CPCG. And here's maybe where it gets truly thought-provoking, something for you to reflect on. Given how many of these conditions we discussed still have unknown etiologies or these complex genetic links, it really makes you wonder how much more we still have to uncover about the fundamental processes that govern our bone health, both in normal function and in disease. And looking ahead, how might advances, particularly in genetic understanding, eventually transform how we diagnose and even treat these conditions, even the ones we currently call benign? Could we move beyond just managing symptoms to truly targeted, maybe even preventative therapy someday? Lots to think about. Until next time, keep digging deeper.